All right. Thank you very much, Tirone. I wanted to say thank you. I'll say thank you 100 more times, but this was a picture of us. You look the exact same. I look a lot younger. So you're doing something right. This is a big screen. So I feel comfortable. A lot of the things I'm going to show have already been discussed, and I agree with a lot of the concepts that have I can speak.
No, it's on.
There we go. I think they're back on.
They're
okay.
back.
Get that right there. Okay. So this is a 56-year-old female presented with very mild symptoms. Her most common complaint was frequent palpitations, a little bit of exertional dyspnea, but mostly a lot of palpitations. No significant past medical history. Exam significant only for a loud holosystolic murmur. And then this was her EKG. And a lot of PVCs. I don't know how, nor can I explain, but my electrophysiologist says the PVCs are coming from the posterior medial papillary muscle. They confirmed with Holter. And a lot of these types of arrhythmogenic cases, I'm not doing these independently. I'm working very closely with an electrophysiologist. So here's the pre-op echo. I think you can appreciate bileaflet prolapse. Annulus isn't really that dilated. Left atrium's pretty large. Significant mitral regurgitation. A little bit closer up view. Thickened posterior and anterior leaflet. A lot of MR. So further workup, we do get a Holter assessment. She's got an 18% PVC burden. We get a cardiac MRI. I'm looking for this arrhythmogenic substrate. She has bileaflet prolapse, but no mitral annular disjunction, no fibrosis in the ventricle or papillary muscles. It can quantitatively confirm severe mitral regurgitation. We do a CTA coronary. She's right dominant. There's no coronary disease. And again, the EKG PVCs were localized to the posterior medial papillary muscle. So first question is, I guess to the panel, would you do anything about the posterior medial source of the PVCs, or would you just repair the valve? Joe, what do you think?
No EP studies, right?
Nothing in the EP lab, just the Holter, just the EKG.
So, and then how did they tell you that this was from the posterior
I
medial
don't
papillary muscle?
I don't know. They can see it. They can look at the EKG. I even confirmed. They can look at it, and based on where the PVCs are, they can localize where they're coming from.
Can you put up the EKG again?
Well, I will try. Let's go back. Yes.
Yeah, so it's monomorphic, and they can localize it. David's going to be talking about this in his talk this afternoon.
Did we get an answer from the panel, though?
Yeah,
Mitral valve repair.
if you look at the reverse polarity in leads 2, 3, and AVF, that identifies the inferior posterior basal wall of the left ventricle. And that's why they're calling this a posterior papillary muscle. I'm not sure how they could absolutely localize it to the papillary muscle. I'll give you that, but it is coming from the inferior wall of the left ventricle.
Okay. All right. So, Dr. McCarthy.
All I'm only supposed to be here moderating. I'm not supposed to answer, but.
Okay.
I mean,
I thought you were
historically.
saying something to me.
Well, I was going to say, get back to the panel. But, historically, we used to just do mitral valve repair in these patients, and we used to say that in the majority of them, the arrhythmia will go away, which is generally true. I don't know that we have data on B, C, and D. I wish we did. I know David has a small series they do in cryoablation of the posterior papillary muscle. I don't know about the rest. But I think of it like a sail, and that in systole, it's got a lot of pressure on it, and whether that is contributing to some of the arrhythmias that they get, and then after repair, they seem to resolve. I'm not quite sure, but this is an area of kind of new knowledge. Marc, what do you do?
In the absence of VTAC, and the patient had no life-threatening arrhythmias, nothing worrisome on the Holter, we would just repair the valve. In the presence of VTAC, that's where you allude to, David's got a really nice small series. There's one other small series in the literature with papillary muscle cryoablation. Not yet certain what to do, but with no dangerous arrhythmias, I would just work on the valve. And as you say, it's this mechanical tugging that causes inflammation of the papillary muscle, which can then lead to fibrosis, which causes a trigger substrate phenomenon. At least that's what people think.
But would anyone ablate that papillary muscle without an EP study localizing the problem to that papillary muscle? Would anyone just blindly ablate it?
I'm going to show you what I did, but.
Yeah, but I will just clear that up. Yes, we would, and the EP study is not of our series, and work both in the trial and in clinical practice. We've not been doing localization, and as Jimmy points out, and I'll show a slide now that you showed this case. Believe me, the EP doctor is going to localize this very specifically, looking at simply EKG. It is not about the MRI or about EP studies. It really is morphology on the EKG, how they localize predominant areas of the PVC origin.
Let me follow that up, David. My EP mentor, John Bueno, used to be obsessed with this problem because he had it. And so he was always trying to figure out what was causing it. And if you go back in the real old literature, there's a lot written about this and not much information learned from anything. But but John's feeling was very strong that.
Can you turn that microphone back on? Try it again, Jim.
Very much like what you said earlier, it's a parachute effect. And with a parachute effect, you're effective stimulating the ventricle. And one reason why I think that sometimes they go away when you repair the valve and you take. Sometimes, as Pat said, they do go away when you repair the valve because you lose that parachute effect. But the diagnosis of this on the EKG is involving a bigger part of the posterior wall than the papillary muscle. And the reason they'll tell you that it's a papillary muscle is because that's the only thing attached to the mitral valve that appears back there on the back of the wall. The fact of the matter is, it's probably coming from a bigger area. And if you really wanted to effectively get rid of this by trying to ablate it so that it just becomes dead and doesn't happen anymore, it would make a lot more sense to ablate not only the papillary muscle from inside, base the papillary muscle from inside, but probably be more important to ablate the posterior wall that supports, the segment LV that supports that papillary muscle, because it's almost certainly where it's coming from. If it were just coming from the papillary muscle, it wouldn't show up on 2-3 and AVF. So I think a bigger part of the wall. But that's...
So, Jim,
but
that doesn't sound good for the ventricle. I mean, if you are ablating the posterior wall, then what's going to happen
I don't mean to imply it's a whole posterior wall, but it was what I was about to say at the end of that sentence. All of this stuff is still speculation.
Yeah.
And it's been looked at for 50 years, literally 50 years.
Dr. David?
I think Jimmy make a very important point. And by the way, if they take this patient to the cath lab and try to find the focus, they don't find in 90% of the cases, except precisely what Jimmy said, somewhere in the posterior papillary muscle or posterior wall. So Michael Gallup, one of the guys who does the work in our hospital, convinced me in 2018, ablate from P1 all the way to P3, and then go straight down to the insertion posterior papillary muscle and go to the septum. I've done 26 cases as of December last year. So up to 5 years follow-up. I have not published yet because the results is a cat of worms. I mean, it's unbelievable. They have 9 patients had the AICG removed because they're all young women. They didn't want to have an AICG anymore. Not a single PVC anymore, no VTAC. We have 6 or 7 patients continue to have VTAC and require AICG after the mitral valve repair. It looks like if they have mitral annular displacement, which 19 of my 26 had, they do better. If they don't have mitral annular displacement, just P2 prolapse, they do not do as well with ablation of the posterior papillary muscle and posterior wall. When you do a MAD, it's simple, because you detach the leaflet, you can ablate the insertion of the, or the leaf is supposed to be, and carry around like the diagram I showed. If it's P2 prolapse with myxomas, with fibroelastic deficiency, to put a probe in between the chorda tendina to ablate the posterior wall proximal to the insertion papillary muscle is not as simple. And you invariably ablate some leaflet as well, which I have no idea the effect of cold ablation on leaflet. You chose a tough case.
So we should move on, but I just wanted to say one thing though, Michael. You said the MR did not show fibrosis, but just remember the MR is very bad at seeing the papillary muscles. You have to use a special MR protocol. It's called dark blood protocol. We've published that. It's not well known, but if you do that, the papillary muscles light up in basically 100% of these types of patients.
So we did, and this wasn't a single physician decision. We had multiple conversations. We worked closely with our electrophysiologists, and they had recommended, since I'm there, can you ablate the posterior medial muscles, which is what I did, and I'll touch on that a little bit later. So thank you. I put that in for a reason, and we had a good discussion about it. So very similar to what Joanna had previously shown. This is a bileaflet case. There is no calcium either in the annulus or in the leaflets. A relatively young, otherwise healthy patient. Take our time. A huge myxomatous redundant posterior leaflet, predominantly involving P2, but really also all scallops. So given that valve, we showed A2, A3, P1, P2, P3. Some of these comments came up earlier. Piroze, what do you think is going to be your repair strategy if you had to choose one of these?
So I usually use neocorday to reconstruct the posterior leaflet and also the anterior leaflet. Unless I find that the amount of valve tissue is too much for that particular annular area, I go ahead with neocords. If I find that the tissue is too much, then I would do a limited resection in order to reduce the risk of SAM.
Joanna, anything different?
No, I couldn't see enough of the valve from that to comment.
And we'll see. I'll show you more. So just to show you what we started off, I think I do very similar to what has been described. I'm, at least in the beginning, focused only on posterior leaflet pathology. I want to get everything posteriorly addressed. I still do mostly resections, especially with a large amount of redundant tissue. And we have plenty of tissue here to work with. Maybe you could, when we look at this, you could say I could have resected even more, but I think I did a pretty generous resection. I keep going here, take a little bit more out, put the edges back together. I will most commonly do a running suture, but I do believe in making sure that the edges are smooth and try not to have that rough edge. So having those inverted or imbricated with that stitch, I think is important.
Which robot is that?
This is the XI robot?
I see you closed the left atrial appendage.
Correct.
I see you closed the left atrial appendage. What's your technique for that to make sure it doesn't open again?
So we do a double layer running stitch. I think in cases where we've had failures, that suture has to be tight. You know, it's easy to just run it and count on your assistant to pull up. So every third stitch, I'm tugging on that Gore-Tex, which is strong, so you can grab it, and making sure that that's tight. I don't do a locking. I haven't moved to going around the sinus and putting a clip on. And the exposure's wonderful, as you know, and I think you can really see that entire appendage the whole time. Sure.
Closing the left atrial appendage from inside is tricky. And you have to remember that when the left atrial appendage is open, is expanded like in a normal heart, it's sort of oval. It's sort of like your mouth. If you open your mouth all the way, when you close your mouth, it's a straight line. And when you decompress and look inside the left atrium, and it's basically essentially closed, it's a straight line. It's absolutely critical when you're closing the atrium, the appendage from inside, that you don't close it like this.
Yeah.
Because
Agreed.
if you do that, it will develop a leak every time. So the first thing you do before you close from the inside is you take a Kittner or whatever instrument you have, and you sort of feel around with it like this. Find out where the proper corners of that thing are when they're closed. Then you close it 2 layers, and it won't open.
And we, start that closure at least 2 to 3 centimeters before the appendage orifice begins, almost as a reduction component to that as well.
That should do it, yeah.
Hey, I had a quick question. I remember distinctly at the STS meeting, Marc Gillinov presented a paper. I think it was in San Antonio, maybe. But he said you never have to repair the anterior leaflet. You just repair the posterior leaflet and the anterior prolapse goes away. Do you still believe that?
We'll get to that on this case in one
Not
second.
never. I hope I didn't say never.
So I did use a little edge to edge on the lateral commissure. You can criticize me for that, not using cords, but I just put a simple figure of 8 there, and that seemed to take care of it. Like Dr. McCarthy, I also will very routinely close clefts, even if they're not leaking. I'm trying to do everything I can to provide support to the entire posterior leaflet. If I got it resected P2, I do have some P1 prolapse. Is it leaking? No, but it could in the future, so why not put a cleft closure suture there and then deal with that? So on that last slide, we had a almost near competent valve, but we knew P3 was also involved. So I also, I could leave and put a ring and be happy. I felt that I needed to provide support to P3, so I put a pair of cords into P3 to reduce that as well. I also closed the P2, P3 cleft after this. The same technique that I think you've seen multiple times. Tirone, I promise I'm going to try your way. I've told you I have. Yes, I'm going to try your way because I know you hate the knots. Okay, and then again, I've already put the ring in. I could be done. There's no leak. To what your point was, Marc, I, again, felt we had anterior leaflet prolapse on the echo. I need to provide some support to the anterior leaflet, so I did put cords to the anterior leaflet as well. I didn't go all the way over to the lateral side, but A2 and A3. And then our final test, I think, looks pretty good. Coaptation zone is excellent, I think. This is not about robots, but when we test at pretty high pressure. We see that red line go up to near systemic, which tells me you could see the aorta fill and everything. So I know, and not that it's a diastolic test, I appreciate that. But I think the echo, we had a pretty good result. Posterior leaflets down, no SAM, good zone of coaptation. Let's go to the next case. This is more of a complication, interested in how others would have done differently. Okay, this one, 62-year-old neuro ICU nurse at a local hospital. Comes to see me, very mild symptoms, if any, but heard a murmur on an annual exam. Piroze, anything that tell me what you see here and anything that you're concerned about when you're thinking about how you're going to repair this valve.
There
High risk of
appears to be mild caudal SAM to start with, and the C-sept doesn't appear to be very wide.
Yeah.
So there's definitely a risk of SAM in this situation.
Okay.
Michael, can I ask you, what's the length of the anterior leaflet? Do you guys routinely measure that on echo before you start the operation?
We do.
And
We
what
do.
was it?
I don't know.
Okay.
I mean, we do. I don't remember what it was at the time, but we do routinely measure the anterior, the posterior, and the diameter.
Because if it's short, then this is really high risk for SAM.
Yep. Yep. Lessons learned. That's why I'm showing the case. Okay. So again, you can see here, I'm fixated, maybe an early mistake, fixated on, oh my gosh, straightforward P2 prolapse. I can fix this.
But
Everything's gonna be great.
But look at the echo, though. You see how short the
I did.
anterior leaflet is, right?
Yeah,
You
I
see
did.
where the coaptation is occurring. It's right in the middle of the valve.
I agree.
Boy, that's going to be.
So can I
That's
ask
going to be
Pat?
exciting.
I have to ask
Let me
Pat,
get to the rest of the case. Go ahead.
well, I want to ask Pat, with his 3 out of 1,100, Sam, what's his approach to this valve?
Just another Tuesday. I mean, not
Yeah,
honestly,
exactly.
Your posterior leaflet is really tall, so you should make your posterior leaflet shorter than you might. Like I might make it about 8 millimeters. I would guesstimate, looking at this, your posterior leaflet was about 22. I would try to make it about 8, so you make it a little bit shorter. Your anterior leaflet looked to me maybe 30 millimeters. You have a little chordal SAM. It's probably going to be fine. And make sure that you put in a big enough ring. So don't go putting in like a 30 or something like that.
Okay, good. I didn't do that.
Okay.
Last view. All right, so just some options. Michel, which one of these would you choose?
The C1.
Okay. Marc, Gillinov, C? Okay. B and D, okay? If you need it, okay? Yeah, I didn't do that. All right, so I'm looking, P1 is a little high, P2, as you stated, Dr. McCarthy, very high. I do a triangular resection. I feel like I'm resecting quite a bit of posterior leaflet. Trim up a little bit more. And then a standard closure there. Let's see if this, go to the next one. So I close the cleft there.
No, I don't close any unless it really leaks. Because I think it has to open like that, not like that.
This is obviously, these videos are sped up, so it's definitely not this quick. All right, so now I'm testing, and I did not put a 30. I thought this sized well to a 34. Anybody gone bigger?
Bigger.
Dr. McCarthy, bigger. Piroze? You can't just say, yes, bigger, because Dr. McCarthy said bigger.
34 looks fine.
You think it looks fine? Okay, thanks. Joe?
Yeah, no comment on the ring, but again, I think it's, especially for this case, I think it's nice when you have the triangular division open to just put 2 sets of cords in to the leading edges that you're going to put back together, because it just gives you another tool afterwards. The resection will probably do the trick. But then after you have the ring and everything, it just gives you 2 cords that are already in that can just lower P2 a little bit more if you think that the coaptation's a little bit too anterior. And it's so easy to put them in advance.
All right, so and then I do one more cleft at the end, P1 to P2. And let's see what this looks like. Joanna, you mentioned on a couple of your videos you wish the posterior coaptation line was more posterior. So did I. It's not terrible, but you'll see what the issue is in a second.
It's like 2/3 up. Yeah.
Now, this is just a different, totally different patient, but when I go through these things with the residents, I wanted to show them what the difference between the coaptation line is. Obviously, this is much more posterior, what you want it to look like, and obviously this case did not have any SAM. Take the clamp off and boom, we've got it. So we're empty, we're on full bypass, we've got severe MR, we got an LVOT obstruction. Do I just put the clamp back on right away and fix it, or would you come off first? Okay, come off first. All right, we come off, fill up, turn off make sure they don't give any epi, add some neosynephrine, volume load, gave a little Esmol. Can I be done?
Looks good.
Looks pretty good, right? Michelle, would you do anything different? Would you go back, rearrest for that?
I think if you correct the situation, I think I would not.
Okay. So she does great, gets extubated, leaves the ICU in a day. It's day 2. She's getting ready to go home day 3. Very healthy. She's a nurse. She knows what to do. We get the pre-discharge echo that we're supposed to always get, right? We're diuresing her like crazy for no reason. Blood pressure's already soft. Her blood pressure lives like 95/60 because she's totally healthy. Heart rate's a little fast. We get an echo, bam, back in trouble. All right, so the heart rate's fast. I don't have color here, but I do on the next one. You could see it. It's the same as it looked like when we first took the clamp off.
What's her hemoglobin, her hematocrit? Because she's hyperdynamic, right?
Yeah, she's like 8.8, 8.7.
Okay. And is she still on the beta blocker, or did somebody stop it?
She's on 12.5 of Loprester BID. That's it. All right, so day 2. Now what do you want? She's sitting on the floor like, oh, I was getting ready to leave. Feels totally fine. I actually use a stethoscope occasionally, and it was, it was no question. I was like, damn it, worse. So take her back. Book her that afternoon, or what do you think?
She shouldn't run any marathons in hot weather. But if you fill her up, she might still be okay. You saw it in the OR.
Okay. Would anybody go right to the OR at this point? No? Okay, I didn't. So we kept her over the weekend. We gave her some volume. I honestly can't remember if we gave her, I don't think I gave her any blood, but I did give her, we had been 40 IV, BID, over aggressive. And so she got fluids, we beta blocked her, heart rate came down in the 60s. Still a little there, but it's trying. The MR's better, right? There's no MR now. What do you think now? Joanna, you want to reoperate or see how she does for a little bit?
Remind me how old she was.
62. Totally healthy.
Look, that echo looks acceptable, but I think you're going to be lucky to get away without some kind of intervention on that valve. You can't keep her blocked and overhydrated forever. As soon as she walks up a hill in dry weather, she's going to SAM.
So we talked about it. We made the decision to keep her on the beta blockers for a couple months and see how it goes. And that's what we did. And I got an echo 3 months post-op.
Oh, wow. Good. That's great.
I think we're okay. So we stopped her beta blockers. She's going to get followed up, not as well as Tirone follows his patients, but I talked to her cardiologist at least and said, please get an echo in 3 months. So we're waiting another month, and we'll see what that shows. Marc, I don't know how we're doing on time.
All right.
3 minutes, okay, so we're
All
good.
right.
Thank you very much.
Okay. Nice job, Mike. So you're not going to do your case? All right. Well, thanks, everyone. That was a great session as well. And so now we are going to break for lunch, and we will be back at 1 o'clock or 1300.